let's get started. We have two very special guest speakers today for you. One is Onslow Memorial Hospital's Chief Medical Officer and Senior Vice President, Dr. Steven Spencer, and also Onslow's very own Director of Pharmacy, Byron Lee. But to kick us off today, we'd like to welcome Onslow's President and CEO, Dr. Burlingame Deal.
Andrea, thank you so much. Good afternoon, everyone. Welcome to the fifth virtual town hall entitled COVID-19 Virus Variants. What is the Delta variant and do I need a booster shot? Great title because everyone's asking that question right now. I do want to take time to thank the communications team for ensuring that we have such a relevant topic in such a timely manner. Also, I want to thank everyone who's attending right now, because not only do we have the OMH staff participating and attending, we have providers, we have interested community members as well. And the community members really do encompass a broad spectrum of folks from the city of Jacksonville, OMH, obviously, Onslow County Airport, the health department, big supporter, big partner in healthcare in our community. Thank you, Chrissy. Onslow County Library, Parks and Recreation, paramedics, Onslow County Schools, Onslow County Sheriff, and the Onslow County Social Services, along with ONWASA. So I'm sure that I've missed folks, but I do want to thank you all for making this a priority to be here, and hopefully we can provide some good information for you and answer questions for you in the open. So this presentation, interestingly enough, was born from a department leaders meeting that we had last month. And during that department leaders meeting, Byron and Dr. Spencer gave a presentation regarding the viruses, and they were able to explain it in a really complex and complicated topic, obviously, in a way that really lent itself to being completely understandable in spite of all the intricacies involved in the virus itself and the variants and vaccines and boosters. So that they really have done an adept job at getting the point across. And we thought that if we offered that up as part of a virtual town hall and opened it up to the community, that it could potentially take away some of the concerns that people have as they move forward with getting vaccines, or at least contemplate getting vaccines if they haven't done it yet. That's my PSA. If you haven't been vaccinated, please ask questions during this town hall, after the town hall, whenever you feel comfortable asking those questions, if it will put you in a position where you feel more comfortable in getting that vaccine. That is for your own protection, the protection of your family, and everyone in the community. And from a selfish standpoint, will not further tax healthcare resources in our community. So Andrea did a great job of introducing Byron and Steve, but I have to say that I refer to Byron as the Chief Pharmacy Services Extraordinaire Director. There's many things that I could use to describe Byron, but he is a great team member and has been for years. So appreciative of his leadership and insight. Dr. Steven Spencer joined us on March 8th, so he's a fairly new member, but rapidly became an invaluable member of the team. And so we're so grateful that he chose us, and we look forward to hearing from him today, as well as learning from the expertise that he brings to bear through either population health management, epidemiology. There's so much he can share with us. So with that being said, I am going to turn it over to Dr. Steven Spencer, and thank you for being here, folks.
Thank you, Dr. Deal. Good afternoon. Just have a few brief remarks before we get to Byron. So since March of 2020, this community has been dealing with the effects of COVID-19. At that time, our community adopted the mask as a new must-have fashion accessory and learned the importance of social distancing while in public. Working from home went from being a luxury to being a necessity. And hospitals and clinics found safer, more efficient ways to deliver healthcare, including an embrace of telemedicine. In order to provide additional resources for the hospital, tough choices were made to account for the possible deluge of patients that would come with those first few weeks of COVID-19. While the numbers in those early days were not as overwhelming for our hospital as initially feared, it did allow us to put in place workflows and processes that would serve us well as the pandemic progressed. So during the winter of 2020 to 21, Onslow Memorial Hospital was tested when we saw what we thought was the peak of COVID-19 patients. We reached a high of 47 patients in January of 2021 that encompassed greater than half of our daily census. The staff held up with amazing heroic efforts, and the hospital made it through this trying time, maintaining our services and high quality care. The approval of vaccines in late December gave us our most effective tool in reducing the effects of the virus. I like to say it was the worst of times and the best of times. Our numbers declined over the spring and early summer, and that led us to believe that vaccines, masking, and social distancing had allowed us to put the worst of the pandemic behind us. Unfortunately, that is not the narrative that we are able to provide our community today. In the past 2 months, the nation has experienced a resurgence in COVID-19 cases and hospitalizations driven by the Delta variant that was first noted in India in the spring and now accounts for over 98% of the COVID cases in the US. We have seen that this increase is more pronounced in the areas of the country that have lower vaccination rates. Onslow County is one of those areas with low vaccination rates. The vaccination rates in the country for fully vaccinated individuals is greater than 50%, and Onslow County is less than 40%. Nationally, we have seen over 625,000 Americans die from COVID since the start of the pandemic. In North Carolina, that's over 14,000, and in Onslow County alone, that's over 170 of our family members, friends, and colleagues who have died from this pandemic. Currently, Onslow Memorial Hospital has over 50 patients in the hospital with COVID, many of them critically ill. Our mission at Onslow is to provide excellent patient-friendly care in a family-centered environment. So just as we did this past winter, we have continued to maintain our services in the hospital, despite all the challenges that have been wrought by the influx of COVID patients. Our staff has again answered the call and made sure that we are able to meet our mandate of providing the highest quality of care to all those who enter our hospital. While we have an obvious focus on the sickest patients who are in need of our immediate attention, it is equally important that we continue to host events such as this town hall. It gives us an opportunity to fulfill another important part of our mission, which is to be a healthcare educator for the larger Onslow County community. We care about you, and we take very seriously our job to make sure that we are providing the most helpful and up-to-date healthcare information to ensure that we keep you and your loved ones safe during this public health emergency. With that, I will turn it over to Byron Lee, the Director of Pharmacy at Onslow Memorial Hospital, to discuss in more detail the changes we have seen in the COVID virus, as well as recommendations concerning vaccines and monoclonal antibodies. Byron?
Thank you so much, Dr. Spencer. I also want to thank Andrea for doing so much to coordinate, as well as the entire communications team, and Dr. Penny Burlingame-Deal, who is a great leader and always an inspiration. So, we definitely appreciate her leadership and guidance at helming this whole process throughout. Today, I'm going to talk to you about the various variants of the SARS-CoV-2 virus. Hopefully, I'm going to be able to make some sense. I apologize that my slides are going to be fairly busy. We did use this at our parts of this at our leadership meeting, which just happened at the end of July, and even in that short time frame, some of the information has already changed. Just as there's a lot of information out there, and hopefully we'll be able to sort through that. But it changes very quickly as we get a handle on things and look at things more carefully. Sometimes the information changes, and the best recommendation becomes different. So we're going to talk about that today, and then we're going to talk a little bit about the vaccines, and there's so much talk right now about additional doses and booster shots. It's kind of difficult to follow all that sometimes, and hopefully by the end of this we'll have a little bit clearer picture, and then certainly we'll be open to questions after the presentation. So I'm going to go ahead and share my screen so you can see the presentation. And hopefully that is visible to everyone. Excellent. Yes. Okay, perfect. So as this is, I will kind of give you a little bit of a caveat in this, occasionally you will hear me refer to the SARS-CoV-2 virus as SARS-2. The original SARS, sometimes I refer to as SARS-1. So if I'm saying SARS-1, I'm talking about the original SARS way back a few years that kind of started the whole process of this infection with coronaviruses. And so SARS-1 is that virus, and SARS-1 is the virus that causes COVID-19 disease. SARS actually stands for the actual letters themselves are the ARS is acute respiratory syndrome, severe acute respiratory syndrome, which tells you automatically that it is a respiratory virus. Let's just take a look here at the virus. This is a computer simulation, obviously, but it almost looks cuddly. It almost looks like a dog's chew toy. I'm sure my little Chihuahua Mojo would be tickled to death to get something like this rolling around on the floor. It has a very deceptive appearance, and so part of that is this whole spike protein structure. This is just a representation of the spike protein, and some of these items that you see, these little, lighter color brownish items, are actually sugar molecules. They're glycan molecules, and these actually help kind of disguise the spike protein so that when it actually enters the body, it has already a built-in disguise mechanism to keep your body's immune system from recognizing it. It's not just on the surface. It's more than skin deep because the virus is also equipped with a number of genetic pieces of information that short circuit your immune system from the get-go. This particular spike protein has the ability, you see these terms here, hip, knee, and ankle. It has the ability to flex in a number of ways and actually get into places that, if it did not have these particular adaptations, it would not be able to get into. So it's a very smart, as far as its design, virus that is very adept at infecting its desired host. And of course, we know that those in this particular case that it has mutated to a point where it is desiring to infect human beings and effective at that process. So this again is kind of the spike protein. I want to talk a little bit, and again, I know, as I said, some of these slides may be a little bit busy, but we're going to hopefully summarize these and keep everything at a nice, easy, understandable level. Over here on the right-hand side was sort of the original thought of how the SARS-2 virus entered the cell. This little membrane here represents the cell. It would be attached to the cell and then would be brought into the cell in the form of a little endosome. This little unit here is where I know some of you remember the whole concept of potentially using hydroxychloroquine as an agent to prevent infection or reduce infection. This little area within this endosome, once the virus was brought into the human cell, this was the area where it was speculated that particular drug, which would keep this area from becoming acidic, because becoming acidic is important for the virus to be able to pass into the cell proper. This is kind of where we thought the hydroxychloroquine might actually work. In fact, this whole process, although it is very applicable to SARS-1 and somewhat to SARS-2, this is not the process that SARS-2 uses to get into the cell. The SARS-2 process is a little more direct in its approach. And what happens is this, you can see this little diagram of the SARS virus here. It actually approaches the cell and binds to an ACE2 receptor. ACE2 is the definition of that is angiotensin converting enzyme 2. It is part of the process. If you're taking ACE inhibitors, you actually, are taking advantage of this particular mechanism because it is part of your body's ability to regulate blood pressure. So if you're taking ACE2 or ARB, ACE blockers, or receptor blockers, this is kind of the desired place of action for those. So the ACE2 is important in that it provides a site for the spike protein to bind to. Usually nearby is this little protease molecule here. Tempris is the short name for it, but the long name is transmembrane protein serine 2. Both of these are very important, and I'm going to show you in just a short second here how that whole process works. In any case, the spike protein is essential for being able to bind to the cell. Once it binds to the cell at the ACE receptor, as you can see here, it's then acted on by the Tempris protease. And what does the Tempris protease do? It slices the spike protein to expose the active portions. This is kind of just a representation of that. This is the spike protein here, as you can see. The purple area is the ACE2 receptor where the spike protein binds to the cell. And then this little item here, that Tempris that we talked about, actually slices the 2 portions of the spike protein. They're called S1 and S2 for short. It slices them, and once it slices them, it exposes specific portions of that cause amino acids to literally attach, literally like a cable to your cell. The next slide I'm going to show you is sort of a representation of what happens once that occurs. Again, it's a computer simulation, but you can see it's kind of a pretty intense process. Let's take a look at that. You see the binding, and it literally pulls itself into contact with the cell, binds with the cell wall, and is actually able to inject its RNA contents into the cell directly. There's no waiting. There's no having to go through an endosome and be dissolved. It's literally just this easy for the coronavirus to bind to the cell. All that is to say that it's a very effective mechanism, much more effective than the original SARS. And then there's another thing that this little slide likes to call the last slice. What does that mean? Well, in this particular process, once the virus has been manufactured, it's released into the bloodstream from the cell. When it's just before it is released, there is another enzyme, a protease called furin, which is an enzyme that actually, remember we talked about the Tempris being able to cut into the spike protein. It actually pre-slices the spike protein. And I kind of like to use this as a comparison. I kind of like to use a bagel as a comparison. What do I mean by that? Well, if you have a bagel and you want to slice into a bagel, if you have one of those fancy guillotine things, it's pretty easy. But if you do not have pre-sliced bagels, it's a little more difficult to get that slice even just like you want it, right? It's a little frustrating sometimes. But if you've got the bagels that are pre-sliced, they already have that slice. It's just a matter of that finishing cut. That's exactly what this process does. It pre-slices the spike protein so that it makes it, it puts it in an activated state that is very, very susceptible to being cleaved by that Tempris protein once it binds to the cell. So this is something, again, that SARS-2 was a little bit different than SARS-1 in its process. So I want to talk a little bit about what are variants, just so that you know. Again, there's a lot of information on these screens. Andrea, very thankfully, is recording the program, and you'll be able to go back and look at these screens as the need arises. So I'm not going to read everything on here, and I know you're probably thankful for that. But I'm going to go over some of the high points. So as mutations occur in viruses, and all viruses mutate, this is just a function of the fact that they do not have their own ability to reproduce. They rely on other cells, and in our cases, they rely on human cells, our own cells, to reproduce. And as they reproduce, their mechanism for correcting mistakes in their genetic code is very limited. So the more viruses that are being grown, the more that mutate, the more difficult it is for those mutations to be constrained and put back into place. Human cells are much more capable of correcting mistakes, but again, the viruses are injecting the material, the genetic material, in this case RNA, into the cell, and they do not have a corrective mechanism. So as a result, the more viruses that you encounter, the higher that viral load, the more mutations occur. Now, sometimes those mutations really don't do much at all. Sometimes they actually create situations where the viruses, it actually makes it more difficult for them to infect cells. But sometimes the right combination of mutations all together result in a whole new strain, or in this case, we use the term variant. Now, there's three different variants, descriptions of variants that we, use commonly nowadays. There are variants of interest, which basically means that this is a variant we've identified, we've looked at the genetic code, and there are some markers that would lead us to believe that this variant is going to be more dangerous than the previous variant. These are changes that theoretically could be a big problem. Then there are variants of concern, and that moves things up a little bit. The variants of concern are variants which actually have been demonstrated to show that their mutational changes are causing either higher rates of infection, or they're more immune to the antibody effect, or they create a situation where our ability to use the COVID testing would be ineffective because we wouldn't be able to identify them. They've changed this just that much. So these are actual strains, the variants of concern. These are actual variants that have been shown to be problematic, not just theoretically it's possible, but they've shown that they are more transmissible. And you can see down here on the end, this one, Delta, is a variant of concern because it's demonstrated itself to be much more effective than the previous variants. And then finally, there is a variant of high consequences. We've not seen this yet, and certainly I think we all would like to avoid seeing a variant of high consequence. But a variant of high consequence is something that, as it says right here, there's clear evidence that preventive measures or medical countermeasures have significantly reduced effectiveness. So these are things that our medications are not able to bring to bay, or our interventions are not able to provide any improvement if this infection occurs. Thankfully, we've not seen that yet, but it's always a possibility. We know right now, those of you that are on the call that are in the medical profession, you know right now that there are bacteria that have developed the ability to basically avoid being destroyed by pretty much all the antibiotics that we currently have to be able to bring to bear. So it is something that can happen, but it's also something that we certainly would hope we would be able to avoid by limiting the number and population that could be infected by the virus. Remember, the more virus, the more chance of mutation. So there are some naming conventions. All the naming conventions for the COVID-19 causing virus are generally there's a few different naming conventions, but the one that's most common is this pangolin system or pango lineage. So sometimes you'll see that if you're looking up information, and they'll give the virus a designation. For instance, they might be this particular designation B1 or B1.1. What that means is that this is a strain of either A or B, which were the kind of the original when we discovered COVID or the SARS-2 variant, they were kind of the original ones that we identified, the A or B strain. B has definitely been much more prominent in its infection of folks than A, but we're not really sure which one came first. It's just that the A happened to be named first and B was named second, but the B has proven to be a little bit more problematic. So when you see these names, B1, as it says, B1 means it's the first variant of the B strain. B2 would be the second, and so on and so on. B1.1 is the first variant of the B1 strain, and so on and so on. And all that is to say that when you look down here at these various strains, you can see that the numbers keep getting larger and larger and larger. As it says here, that we generally will try and limit it to 3 numbers, and once it reaches 3 numbers, once there is a variant of something that's already been designated with 3 numbers, we kind of give it an alias. So in this case, this one here, B11281. We renamed the B1128 and we called it P. And then it became P1, but that is the equivalent to B.1.1.28.1. Now, one thing I wanted to mention here is this one here is the one that we're dealing with right now. As Dr. Spencer said, 98% of the infections in the United States right now are this particular variant, and that is the B.1.617.2 variant, which we designated as the Delta variant. Now, what does that mean? Literally, it means it is the 617th variant of B1, and then the second variant of that 617th variant. That's a lot of variants. There are literally hundreds, even thousands of variants that have been named and identified. We've literally, looked at their genetic code and seen that these can be problematic. When we see that they're problematic, the World Health Organization then gives them an additional designation, and that is a Greek letter. Back in the old days, it kind of used to be, well, we'll name everything after where it was first discovered. The Spanish flu, or British, whatever. That really is not an accurate way of naming them, just simply because we know that they showed up there, but that could have easily been the result of someone flying in from another country, and you don't want to pin something on a particular country and have it be connected. Oh my God, the Spanish flu, for God's sake, don't go to Spain. You don't want to pin something on with a country designation that kind of implies that, well, they're the reason for this. That's not the case. And so using Greek letters just makes it easy to identify. But when you hear Delta, the Delta is the B.1.617.2 strain. FYI, there are already 3 different recognized strains of Delta. They ended up being called AY. So it's AY1, AY2, and AY3. AY basically is the thing that represents B.1.617.2. And then the 1, 2, and 3, again, would be the AY1, AY2, AY3. Those are all Delta variants. So they have additional mutations that would create what we think would be potentially additional problems. All right, very quickly, I just want to go through and say this is a reference chart that talks about the way RNA is coded. And you see these letters around the outside, R, L, D, E. These represent amino acids. And that's going to be important for us to be able to talk about the mutations of the Delta variant that we're about to discuss. So when you see R, it means arginine. That's the short for argin. P is short for proline. M is short for methylthionine, etc. So this is just a little wheel to help you, and again, it will be in the recording, so you can kind of refer to this. But each of these is kind of demonstrative of how those particular amino acids are pulled into the RNA code. Basically, arginine, for instance, is a result of the C, G, and U, C, A, or G. Any of these 4 will result in arginine, but C, U will result in leucine, or C, C will result in proline. So if you change a part of this, in other words, if this C ends up becoming a G inadvertently by mutation, then you get arginine instead of proline. All right, so that all that is to say that this is kind of the discussion of what makes the Delta variant more effective. What are those particular mutations that make the Delta variant more problematic? So there are 4 main mutations that we're going to talk about today. There's actually 13 identified mutations of the Delta variant. And I just want to point out that this represents the spike protein. This represents the ACE2 receptor. And these various locations are where the mutations have occurred. And we're going to talk very briefly about what those mutations do. What advantage do they give the Delta variant that make it different? So the first mutation, you see this one, P681R, which basically just means at the 681st position along the viral RNA, this particular amino acid, proline, has been changed to arginine. We just talked about proline and arginine being very close together, so it's understandable that a small mutation would create that substitution. What does that do? Well, let's go back and look. This particular mutation is right here at the seam of the S1, S2. It's at the part where the 2 parts separate. We talked about what Tempress does and how Tempress cleaves a particular portion of the S1, S2. I like to kind of compare this to the difference between a deadbolt and a chain lock on a door. So if you've got a door that has a deadbolt on it, it's pretty difficult to get through. That particular representation is what the original SARS-1 was like. There was literally one amino acid that created that hinge between S1 and S2, and it was pretty tough to break through comparatively. With SARS-2, what happened was that one amino acid was changed to 5. So now instead of a deadbolt lock on the hinge, you've got a chain lock on the hinge, just like you would have, if you were securing your door, to your house. A deadbolt's always going to be more effective and harder to get through. So by creating this 5-strand chain, it made the S1, S2 hinge much easier to break through. And we talked about the fact that this particular variant, the Delta variant, actually made a substitution from the original SARS-2 and substituted the proline with arginine. What did that do? That actually created a much more cleavable virus. So the difference between SARS-1, when it was ejected from the cell, literally only 10% of those viruses were in an activated or pre-cleaved state. Remember, we talked about the pre-sliced bagel. Only about 10% of those bagels were pre-sliced. So it was mostly not pre-sliced. With the SARS-2, the original strains, they had a 50% rate of cleavage. That's what made them so much easier to infect. And then with the Delta variant, 75% of the Delta variant that is released is already in an activated state. So when it hits, a host cell, it is ready to infect much more easily than even the previous SARS variant. Some of the other variations that occurred, this particular variation, which is at a point in the spike protein is again at the 2 points of the S1, S2, but in this particular variation, it actually exposed a portion of the inside. So it actually created a point where the S1 and S2 didn't even need to be cut. There was a portion already exposed, and that exposure made it way easier for it to get near the ACE2 receptor, which again we know is important for it to be able to get into the cell. There are a couple of different mutations down here as we go through. You notice that these are kind of at the point of binding between the ACE2 and the actual the spike protein. These both made it much easier and much stronger in its bond to the ACE receptor, so much stronger in its bond to those cells, but it also created a situation where now that portion of the spike protein didn't look quite the same. So it made it more difficult for the immune system, the antibodies, and this is one of the, these two are areas where you hear about, well, the Delta variant is a little more resistant to the antibodies that you've made from a vaccine or that we've received from the various monoclonal antibodies that can be infused. So these, again, are important because they create something that's slightly different and less recognizable. But at the same time, let's bear in mind that these are only small portions of the spike protein, very specific small portions. And so there is plenty of area that is still very recognizable. And we're going to talk about that when we talk about, the importance and effectiveness of our vaccines. So multiple mutations, what does that add up to? It adds up to Delta having a viral load that is literally 1,000 times greater than previous variants. Not only is it 1,000 times greater, it's more easily transmissible because it's highly activated, 75% activation state. It's not as recognizable to monoclonal antibodies and the antibodies that we form based on having received the vaccines that we've received. It has a truly strong attraction to respiratory cells. And so once it hits respiratory cells, because of that specific mutation, it is very, very, it really gets in very quickly and very effectively. And then the thing, again, about it is the symptoms are about the same. Yes, that is true. It's not like the symptoms are necessarily worse, but it's far more effective at infecting folks, and therefore with that higher viral load, it can be more problematic. Particularly as you see here, especially in younger people, those that are less than 50 years old. And then finally, it seems to affect unvaccinated people more so than it affects vaccinated people, in that it accounts for about 97% of those hospitalized with COVID-19. Now, like any vaccine, no vaccine will keep you entirely from getting that particular virus. The concept is that if we can train your immune system to recognize that infection, that hopefully will create a situation where that virus will not be able to do nearly the damage it would if your immune system had never encountered it before and had no idea what was coming at it. So that's kind of what the concept of vaccines is, and that's any vaccine, not just COVID, any vaccine. If you get the polio vaccine, you could acquire polio. You absolutely could. If you get the measles vaccine, if you were in contact with someone who had measles, you could get it. If you get the chickenpox vaccine, you absolutely could get chickenpox. But the concept is if we make it so that your body recognizes it right up front, your immune response is geared to the fact that it can keep that disease from progressing anywhere near as far as it would if it did not have that advantage. So vaccinated, again, seems to respond much more effectively. Now, we kind of talked about the mutations and what these mutations mean. We've talked about how that increases the effectiveness of this virus. It has been called one of the most effective variants of the COVID virus yet to be discovered because of those variations. But I want you to take a quick look at this particular chart, which discusses the percentage of folks either who will potentially be infected or potentially hospitalized as a result of COVID. Look at these numbers from studies. These were done in the UK, Canada, Israel, and Scotland. And these are, again, are just some studies that were done to look at, if this patient has received the first Pfizer vaccine, how likely are they to be infected? Well, after the first Pfizer vaccine, the UK study saw about a 33% incidence of infection and a 56% incidence of infection in the Canadian study. But look at what happens after the second vaccine. All of a sudden, we're talking about 88%, 87%, 64% in Israel, and 71% still very effective at preventing infection. Still very effective. If a vaccine was released on the market with a 50 or 60% prevention of infection rate, that would be an approved vaccine. I will say we have vaccines now today that is their effectiveness, and some are even on certain years, no names mentioned, as little as 6% effective. However, this vaccine is very effective, even still, and this is against the Delta variant. Look at this down here. This is an even more compelling piece of information. What about preventing hospitalization? If I did get the vaccine and I do end up with COVID, what about will I have protection against it being severe? This is that measure. After the first shot, it's still a 78% chance that you will not have to be hospitalized as a result of being infected with the Delta variant. And after the second shot, look at these numbers. The UK found a 96% protection of prevention of hospitalization, and in Israel, 93%. That is, again, amazing protection from a vaccine if you compare that to many vaccines that are existing well before the SARS-2 vaccine. For the Moderna product, you have kind of very similar information with regard to this first shot, and one can extrapolate that the second shot would be even higher in both cases for prevention of infection. The J&J, as you know, is a single-dose vaccine. It is, slightly less effective at preventing infection than the other two products, Pfizer and Moderna, because they are a two-shot system. But it is still very good. And look at this information. J&J is actually better at defending you against the Delta variant than it is against the Alpha variant that it was originally created for. So it is still a very effective vaccine. All the vaccines have proven themselves, even against the Delta variant, to be effective. Maybe not quite as effective at preventing infection as they were against the original variants they were created from, but still a very compelling amount of protection with just the two shots that we've already received if you happen to be vaccinated. Again, why are the vaccines effective? Well, they're effective because of multiple reasons, but number one is, again, we talked about those specific mutations in the Delta variant. Well, there's plenty of areas that still haven't mutated. So that's again, those antibodies that you create as a result of the vaccine are binding to areas that are not necessarily part of the mutation zone. The human immune system, again, is more complex. We've got B and killer T white blood cells that, again, our whole thought process in utilizing a second dose was to try and activate this part of our immune system, which remembers, even though antibodies start to wane or start to decrease over time, the memory of these killer T cells and B cells and the dendritic cells that produce antibodies on demand is critical to being able to maintain protection against any variant that might happen to show up. Again, just as the virus mutates, our own immune system mutates and changes to anticipate issues and respond to new infections or mutated processes. And again, in populations where greater percentages of people are vaccinated, the protection against new variants is greater because there's a much smaller pool of individuals who can be infected in a serious way. So that keeps the possibilities for variants much lower in populations that have higher vaccination rates. All right. So we've talked about this whole concept of the Delta variant. We've talked about it being wickedly adept at doing what it does. We've talked about the fact that the vaccines are still to this day very effective, but there are recommendations by various groups, of course, the manufacturers, as well as the FDA and certain other professional, health groups, scientific studies that say that if you have a patient that is immunocompromised, what does that mean? Well, it means that their immune system is not responding quite the way you would assume a normal, healthy person would respond. Who are these people? Well, if you're receiving cancer treatments where you're getting medications that are affecting your white blood cell counts and so on, that diminishes your immune response. Organ transplant patients, of course, have to take medications to suppress their immune system to keep the organs from being rejected. And again, you see the various other indications that might merit an additional dose. Why would you need the additional dose? Well, it's because if you are an immunosuppressed patient, you may not have developed an adequate response to that second shot. Now, is that an absolute? You definitely will not have developed an adequate response? No, it's not. You could well have developed an adequate response. But again, these are the folks that are most likely to be at risk. And so conceptually, if we give an extra dose, hopefully we will be able to get their immune system to respond much more adequately than just the 2 doses that they've already received. So we're just talking about immunocompromised patients. Those are the ones that right now today are recommended to get an additional dose of the same formulation that they've already received, preferably the same brand that they've already received. And then they are looking at the Johnson & Johnson product to see if potentially an additional dose would be beneficial if an immunocompromised patient received the Johnson & Johnson product. We've got this whole thinking process now. Well, if I'm immunocompromised, or if I'm not immunocompromised, do I need another shot? Okay. These are what we're calling boosters. This is the concept of the booster. I'm a healthy person. I had my 2 shots and I responded appropriately. Do I need another shot, a booster shot? And then if I need another shot, what does that shot need to be? What is the formulation of that additional shot? So I want you to look at this, again, just as with any other vaccine, over time, your immune response is going to diminish. If you get a tetanus shot, it's going to last for about 10 years. Some would say 5 years. But after that point, you need another tetanus shot. You step on something and you go into the ED and they say, yeah, when was your last tetanus shot? Well, we're going to need to give you another one because it's been a while. What about flu shot? You get the flu shot literally every year. Its actual effectiveness, it lasts somewhere around 6 or 7 months at most. And that's why we try to time it during the most likely period that you would encounter the flu virus. And then you have things like rubella or German measles, which folks get vaccinated to. But then you have all the time folks come in and you take their rubella titer and it's 0. So they need to be protected from that, and they would have to renew that vaccine. All vaccines have this diminished response over time, but the question is, what time frame are we looking at? The Wall Street Journal literally yesterday just released an article that said that time frame was probably more a 6-month time frame, similar to the time frame for the flu vaccine. The manufacturers have, prior to that, said an 8-month time frame would be the recommended guidelines. It still remains to be seen what is optimum. But again, if it's been 8 months, if it's been 6 months since you received that second injection, is it conceivable that you need a booster? Well, potentially. And then if you do need a booster, does it need to be the same formula as before? Or should it be the same formula but with a little bit lower dosage because you might have a response, a strong response to the booster dose if it's the same dose? Or is it a revised formula, which Pfizer has suggested specifically they could come up with a formula that would include specific variants, Delta variant or Lambda variant or whatever the variant of the day might happen to be, to include more enhanced protection for those specific variants. We're expecting sometime around the third week or so of September for there to be a decision on this. The Wall Street Journal article, again, just yesterday, suggested that it probably would be, at least initially, the same formula as was received before. But there's still, again, a lot of individuals who say that a protection rate of 96% from the Delta variant does not merit a booster. We'll have to see what the FDA eventually decides. But again, at this point, it is conceivable that if you received your shot 6 to 8 months ago, there would be a recommendation for you to receive a booster dose, again, to bring your immune response back up into that extra high range that you saw when you initially received your injection, your second injection. What can I do in the meantime? Well, again, this star is right here for a reason. Get vaccinated. It is still the most effective way at preventing serious illness from the SARS-2 virus, the COVID-19 causing virus. It is still extremely effective, and we have seen statistically of those individuals that are seriously impacted or even die from the COVID virus, 99.99% of those who are vaccinated are not in that category. 99.99%. That's better than Ivory Soap's purity. I think it's around 99 and 44/100ths. Again, that is extremely good protection. Even if you're, do I need to wait for the booster? No, you don't need to wait for the booster. This current formula is very highly effective still. What else do I need to do? Obviously, washing your hands is so important, maintaining social distance, and then wearing a mask, particularly if you're in a group with unknown vaccination status or you're in enclosed indoor spaces. We know that folks who are vaccinated can potentially get the virus and carry the virus. Even if they're not being severely impacted by the virus, they can get it and carry it. And so being around groups of people in an indoor setting, it's just so much smarter to wear the mask. Who are you protecting? Again, mostly you are protecting those around you, not yourself. And then finally, if possible, please make sure that you cover your nose and mouth, both, not just one or the other, and preferably something other than a cloth mask, because those are not overly effective at preventing pass-through. It's better than nothing, but they're not overly effective. Finally, I want to just address a new therapy that we are offering here at the hospital. It's the Regen-Cov monoclonal antibody therapy. Briefly, how this works is these little Y-shaped things here are representative of the monoclonal antibodies. They bind to the spike proteins, and by binding to the spike proteins, they prevent the proteins from being able to bond with the cell because they can't connect with that ACE2 inhibitor. These are very effective. Currently, there have not been variations that are completely resistant to this Regen-Cov therapy. And we use it, again, for people who are COVID positive. We use it to try and keep them from advancing to the point where they would be hospitalized. If you have not actually shown negative, but you've been subjected or exposed to individuals who are COVID positive, let's say your spouse, has gotten COVID and is positive and you're currently negative, within that first 96-hour period, we can use this product as a means of keeping you from becoming infected. Again, I apologize for the length of time involved. It's a lot of material and I'm a little long-winded, but I will take some questions if anyone has any.
Thank you, Byron, for that. I think Penny said it, pharmacy extraordinaire for sure. One day you can teach me some things, okay? All right, so yes, we are available for questions, and by we, not me. You don't want to know my answers, but Byron and Dr. Steven Spencer are here for us. So if you have anything, please use the hand raise function. It should be at probably the top right of your screen-ish, or the chat box, please.
Dr. Lennox Williams here. Can I ask a question?
Absolutely, Dr. Williams.
Okay, so first I want to make a comment that I just had my 3rd dose today. And, I just want to say for those of us who don't appreciate it, what we just heard from Byron is a master class. I have never, ever heard anything that this is good. Freaking amazing.
Thank you, Dr. Williams.
Well, it's honest to God, you didn't talk down to people and you gave all the information. It was a master class, and thank you. I just have two things to say, which is that I really think that, first of all, you talk like real people, so there's an authenticity there. But there's a lot of research behind it, which I see. And I think that, we really need to have Byron go out there and talk to the Rotary and the commissioners and so forth, because I think he talks in a way that people can understand and believe. Authenticity is so important. There is one large outstanding question which nobody has really addressed, which is of great concern, which is safety. Women of childbearing age, pregnant women, and so forth. This is an extremely safe vaccine, but there are risks. The overwhelming evidence is that it's way safer to have the vaccine than to get COVID. But I just want to toss that out there. Thank you.
Yeah, I think that is an important question. And again, I appreciate Dr. Williams being with us today. Dr. Williams was very instrumental in us, being able to move forward with this new monoclonal antibody treatment, and was a strong advocate for that. I think the real answer for looking at this vaccine's effect on pregnancy is number one. COVID is far worse. That's number one, as Dr. Lennox Williams just mentioned. But number two is the fact that our statistical data, having looked at a database of literally hundreds of millions of people worldwide for the Pfizer and Moderna vaccine, certainly tens of millions for the J&J vaccine, there has not been any compelling evidence whatsoever that would indicate that this drug is specifically in any way harmful to individuals who are pregnant. In fact, it is, according to the statistical information, very easy to see, looking at that real world example, that the consequences are very, very mild side effects. Of course, anyone can react to something, any drug, in a way that is severe, as an allergic reaction or whatever. But as far as this vaccine, the real world evidence that it creates any issues with pregnancy at this point, having given it to many individuals who are pregnant or recently delivered, no indication whatsoever of harm to the baby or to the mother, either for the individual who is pregnant or breastfeeding at this point.
Thank you, Byron, and thank you, Dr. Williams. Maria, you have your hand up. I don't want to leave you out.
Oh, yeah, thank you. First of all, it was a wonderful presentation. Thank you all so much. My question is, how many employees at Onslow Memorial are vaccinated?
I will defer to either our CMO or CEO to give that answer.
I'm deferring to the CEO.
Okay, currently the percentage is about 60% for fully vaccinated staff members. So we do have a fairly decent population of folks who haven't gotten it, and really they have their reasons. Our intention and hope as we go through things like this and try to present information to folks in a meaningful way, which Byron did an excellent job. Wholeheartedly agree with everything Dr. Williams and the others of you have said about how understandable it was, even though it was a really complex topic. But that's why it's so important to have conversations like this, so people remove some of the questions, the unknown, the uncertainties, and support the vaccine, because the alternative to be unvaccinated and then to contract the Delta variant is much less desirable.
Absolutely.
So if 90% of the hospitalized patients right now, and you heard actually the statistic that Byron gave was a little bit worse than that. If 90% of the population in the hospital right now, hospitalized patients, are unvaccinated, that tells you something. If 99% of those patients that are hospitalized and die, 99% are unvaccinated, that tells you something more. And for my staff, employees, providers, community members, it is a travesty to me to think that you all might experience tragedy in your life that was preventable.
Right.
So a loved one dies because of COVID when it was preventable.
Thank you.
Thanks, Maria. Thanks, Penny. Kayla also has her hand up.
Hi, I wanted to ask 2 questions. Well, technically 3 questions. So what is the needed efficiency, you said, like the efficiency rate to put the vaccine on the market?
Actually, a vaccine that is between 50 and 60% effective would be considered a strong vaccine candidate and would likely be approved. Okay. Again, as long as there were no specific side effects that would, prevent that approval or other things, but just specifically based on efficacy, somewhere between 50 and 60% is considered an extremely effective vaccine. And as I said, I won't necessarily mention names, but look at the effectiveness of some of our other vaccines, and you'll see that almost none of them are in the 90-some% range that the COVID vaccines are in.
Okay, and then what is the rate that it needs to be at to be passed by the FDA or any of those agencies that?
That would be the same number. That is what again the FDA would look at ideally. If there were other compelling evidence, again that would be looked at as well. But generally, that would be the considered efficacy.
Okay,
or
and then
approval.
Oh, sorry.
That's right.
What was the differentiation between variants of interest and variants of concern?
Okay, so a variant of interest means that we've identified specific genetic sequencing that would imply that there are mutations that could be more dangerous than previous variants. That's a variant of interest. A variant of concern means that not only is it theoretically possible because they've got the genetic coding for it, but their actual combination of mutations has been proven to be more problematic. Either more people are actually being infected. I'll give you, for example, the epsilon variant was a variant of interest because there were certain genetic markers that would say this is going to be a problem. It literally has been removed from the list entirely because it did not pan out. There were other mutations that ended up making it not very effective at being passed along. So, again, we can identify there's this change. We can see that. We've coded that sequence and we see that is a change and it could be a problem. But if it doesn't pan out, it just stays a variant of interest, or eventually, if it doesn't show itself to be of any concern at all, it will be removed from the list entirely. But that's the difference: theoretical versus actual real world evidence that it's causing worse problems.
Thank you, Kayla, for the great questions. Yeah, I just want to I know we are over our time and it's a great topic. So please, if you feel free to fall off or leave if you need to. It's a long day and it's 3 o'clock in the afternoon. But if Byron and Dr. Spencer are able to just stay on just a couple more minutes, and hopefully we can get through some of these questions in the chat.
Yeah, more than happy to. All
right, thank you. So we have a question from Jennifer Battle. What about people who have had COVID and not vaccinated?
And with that question, Jennifer, is that are you asking should they be vaccinated if they've had COVID? Okay. Absolutely.
Or about like, because, you know, they might have antibodies or something.
Absolutely. And of course, yes, you will develop your own antibodies in response to COVID, particularly if you have recovered from COVID. But here's the thing. The COVID strand itself is 35,000 plus base, RNA base units, 35,000 plus. Among that coding is some very effective pieces of information that literally short circuit your body's immune system. It keeps you from not only recognizing the virus, but it keeps you from developing a memory response where you involve your T and B cells. It is very effective at that. The vaccine, on the other hand, is a very specific piece of a copy, so to speak, of that code, a man-made copy. And that allows your immune system, because it does not have that additional piece of information that says, literally drive their immune system into overdrive and create cytokine storm, or make their immune system so that it doesn't respond. They can't release interferon or interleukin. All of that information none of that is in the vaccine. It is specifically the spike protein itself, which allows your body to develop a full immune response. Again, assuming that it's an immunocompetent patient, a full immune response to this piece of information that literally gives your body the ability to recognize the virus as soon as it enters your body system. So yes, you will get some protection from having had COVID for a period of time, but not a very long period of time, generally between 6 weeks to 3 months or so, where those antibodies linger and eventually are removed, but almost no memory response at all for your dendritic B and T cells.
Great.
And just to add, there have been some great studies that have come out in the past few weeks that point to exactly what Byron has said, is that you do receive protection from an infection with COVID, but the response is not as great. You have a less likelihood of being hospitalized and getting severe infection than a person who's never had COVID, but it's not nearly the same effect that you get with the vaccine.
Great. I think someone should post that somewhere, those two answers. Kim Pierce asked, what are the guidelines? And you might just, how you answer this is probably should focus on the medication and not the news, but what are the guidelines for prescribing ivermectin? If I pronounce that wrong, I am a supply chain director.
That is Byron's favorite topic. He loves it.
Should we come back to that question last?
No, Byron loves it.
And we can't talk about what happened in Arkansas. We just need to talk about the question. What are the guidelines for prescribing ivermectin?
Indeed. So ivermectin is, as some of you may know, and others may not, because you've only just heard that word, and it's a big, long word that you're like, oh, it could possibly work for COVID. Ivermectin is in short, is a dewormer. It is something that we give to people who have pinworms or other worm, also called helminth. Those infections with worms, we give them ivermectin, and in the doses that we're able to achieve, the blood levels we're able to achieve, it is effective at destroying the systems of these worms so that it kills them. There is theoretically a possibility that ivermectin could be effective, but remember we talked about hydroxychloroquine having a possibility of being effective, but it never really panned out. There is a possibility, because of what ivermectin does literally at the ribosome level, that it could interfere with the translation of the viral protein, and that's the concept. The unfortunate thing is most of the evidence that has been looked at, and certainly all of the evidence that has been conclusive, has demonstrated that the doses that we would literally need to get of ivermectin would be almost impossible for us to consume for it to be effective enough to affect human ribosomes in the same way as it does worm ribosomes. We're a little bit higher along the food chain than the worms are. Well, I guess that depends on whether you're looking at our view or the worm's view, but we're a little bit higher along, and therefore the doses required, no matter how much you get from the veterinarian, you're not going to be able to consume enough. It's generally not a harmful medication. It's a very inexpensive medication, but is it going to help with COVID? The evidence says no.
Great, thank you. All right, this question is from Lisa Daniels. How can we get more information to the public to help individuals decide to get vaccinated? There's a lot of mistrust surrounding the vaccine. I'm just going to start and say that we hope this virtual town hall is one step we can do that. There's my shameless plug for the communications team. We have about 48 outside of OMH employees that registered for this town hall today, which is very exciting, but that's 48 people that we were able to share some new, hopefully some very good, very knowledgeable information with. And that's one step we can do. So Byron, Dr. Spencer, Dr. Penny, anything else for that one?
Yeah, I would just reiterate that I think the town hall is really important. We've had constant communication with the media, discussing, what's happening at Onslow, as well as our goal to really get as many people vaccinated as possible to protect our community. We've had direct conversations with Department of Health, how we can partner there and other community organizations. So I think, we have a mandate to do this, and we're trying to reach as many venues as possible.
I think the science and the statistics are compelling. That's what I think is compelling. What I had just talked to you about, the 90% of the folks who are hospitalized right now are unvaccinated. 99% of the folks who are dying from it are unvaccinated. So I think that those are very compelling statistics to share with folks. And here's another, I'm going to offer this up, but I'm going to offer it up on behalf of others. So if there are questions that you encounter as you try to influence others to become vaccinated, send them our way. Send them to Byron, send them to Dr. Spencer, send them to Aaron. We are here, send them to me. If I can't answer it, I will get it to someone who can. But we're here to provide as much information. You've got a great health department who can also contribute answers as well. But whatever we can do to bring someone to a place where they understand how vital this is within the community, but also within their own families, we're here to do that. But I do think the statistics and the science of it all is very compelling.
Penny, I absolutely agree with that, and I definitely think that Chrissy and all the folks at the health department that have been dealing with this, all of the folks here in Onslow County that have been dealing with this since the inception, have worked hard to inform themselves and try to figure out what are those things that are going to be compelling to individuals that are on the fence about vaccination. Again, I think it's important not to browbeat or intimidate folks who are, again, afraid of potentially getting vaccinated. Something new comes out, nobody wants to be the guinea pig. Nobody wants to be the first one. I recently had an opportunity to talk with one of my own staff about the fact that she decided to get vaccinated after having been a holdout for quite a while. And I asked her, I said, what was that thing that compelled you to decide, I'm going to do this, having, previously thought differently? And she said, you know what? I just stopped looking at TikTok and Facebook and went to some actual verifiable. I did some research and I asked some healthcare professionals that have been looking. I'm looking at, having worked here at the hospital every day, I'm looking at people lying in ICU that are, we're not talking about all of these people are, old and just about, no, we're talking about young people, because a lot of the older people, remember, were the first to be vaccinated. She said that fact, looking at that and seeing with my own eyes and knowing what was happening and talking with folks who were not, beating me over the head. My physician tried to beat me over the head with it and scare me into, that's never going to work. Nobody responds well to that. But being able to either explain or direct someone to resources, as Penny said, either us or the health department or the various other, folks who are diligently trying to provide vaccines to this area. The UNC website, the Onslow Memorial Hospital website, the county website, all of them have links to, COVID resources, and doing that research and seeing what statistically is really happening, as opposed to listening to individuals on TikTok. it absolutely leads to one conclusion, and that is that vaccination is your most effective means at preventing serious harm due to COVID. Here now, right now, today, that is the most effective thing that you can do.
Okay, so thank you. Kimberly McCluskey, she asked, so if someone received the first 2 doses of Moderna and they get a booster, can it be Pfizer, or should you really stick with what you began with?
Ideally, you should stick with what you began with. That is the formula that you received. Now, again, there are circumstances where if for whatever reason you cannot get the same brand, it is theoretically, and again, this is backed by, FDA agreement that, or CDC agreement, excuse me, that receiving an alternate brand would provide additional protection, just as the same brand would likely provide the same protection. But again, it's a little different. The formulation is different. Could you have a different, effect or an allergic reaction? You already know you're not allergic to the one formula, so that's at least something that you can kind of mark off the list. This one's good. So yes, ideally it should be the same brand, but in extenuating or extreme circumstances where that absolutely cannot happen, where you have access to the other brand, you can in fact be, receive an additional dose of the alternate brand once that has been through, again, once the FDA makes their decision about the 3rd week of September and says, yeah, it's a go.
Great. Thank you, Byron.
Hey, Andrea,
Yes.
this is Erin. Can we go to Jen's question at the end, just for those folks who are still on here, because I'm sure this is something that people are asking or they're still hearing. And so I would love for Byron has a wonderful response to this. And that's, what do you say to people that don't want to get vaccinated because the vaccine was developed too fast? And it actually wasn't.
So mRNA incorporated into a lipid molecule for delivery of a vaccine. This has been around since literally the 60s was when this was kind of first looked at. It was a theoretical thing, and over time it has been developed. But if you want to talk about the speed of development, let me give you a slightly scary statistic. When the entire genome of the COVID virus was released by scientists in China, it was released on a Friday, if I remember correctly. By Sunday, Moderna literally had their vaccine candidate already prepared. Why? Well, I talked with someone the other day, and I said, it's kind of like a computer code in a way. Once you've got the code, it's very easy to duplicate or copy. You know what I mean? Think about when you open a document. If you need to put something that's a quote from somebody else, you don't have to retype the whole thing. You go and copy and paste, and there it is. This vaccine was, again, because of the particular approach using mRNA to get your own cells to do the work. Yes, it was developed fast, but it was developed fast because it is a technology that is very easy and portable with regard to coming up with new variations on that particular vaccine. So you're not waiting like the old school. You're not waiting for viruses to grow in chick embryos. You're not waiting for viruses to grow in chimpanzees and like polio, chop up their poor little chimpanzee organs and trying to extract polio pieces, from them. It is not based on a live virus. It is a copy of that RNA code, and that code is very easy to develop. Not only that, but because this vaccine was developed in cooperation with the government and with NIH, they were able to do multi-phase testing simultaneously because the government recognized quickly this is a dangerous virus, and we want to make sure that we do everything we can to develop this in a quick, certainly safe, but efficient way. And so they were able to do multi-phase testing at the same time. And by literally, as you know, by the end of 2020, we actually had a vaccine candidate that had been tested in phases and was ready to go, by the end of that time. That is an unprecedented development time frame. And yes, it is quick, but it's because the technology used is very easy to adapt. We right now, in the very near future, have an mRNA version of the influenza vaccine that could prove to be very much more effective than the current one. And we also have an unprecedented new vaccine for HIV that could prove to be extremely, impactful. So it is quick, but it's because of the design of the process. It is very easy to make this mRNA, use this mRNA approach.
And I think the other thing that may be comforting for some people is, so that initial research looks at efficacy. So it looks at a controlled trial where some people get the vaccine, some people don't. You see what happens to death and severity of illness and getting the infection at all. But the effectiveness research is unprecedented as well. So that's what happens in the real world. So you give it to people outside of a study and you follow those people, and people are going to give you all the side effects and adverse events and everything that's happening with the vaccine. And we've never had the uptake of a vaccine with this number of people this quickly. So the effectiveness research that's happening is unprecedented, and we've never seen anything like it with the vaccine. So that should give people some comfort as well. As Byron said, there are hundreds of millions of people who have gotten this vaccine, and we are collecting so much data on it, much more data than we are on ivermectin, by the way. So that should give people some comfort as well.
Great, thank you both. Sheriff Miller asks, can someone who tests positive get vaccinated, or do they have to wait until they are no longer symptomatic?
Ideally, they should wait until they're not symptomatic. But technically, if you have had COVID, if you have actually had COVID and your symptoms have have gone away, then you can literally be vaccinated at that point. Now, again, because you have antibodies residing in your system from having had COVID, your reaction to the medication, to the vaccine, may be a little more intense. Maybe you get fever and chills. Maybe you get it's kind of very similar to when you get, occasionally get the flu shot and you end up feeling, a little uncomfortable. But those symptoms will resolve in a very short period of time. Again, if you want to kind of avoid that, if you wait a little bit longer, that is conceivably okay as well. But again, you could theoretically, once your symptoms have disappeared, you can get vaccinated. That is the recommendation currently.
Thank you so much. I'm asking for my people because that question came up quite a bit.
Yes, sir. Absolutely.
Great question. Christina asked, does the virus change with each transmission?
That's a great question. Almost every virus has changed with each transmission. Remember, we talked about the fact that the virus mutates as a result of not having its own ability to replicate itself. Every human being on this planet has their own little replication system. We're each different, and as the virus encounters new individuals, yes, absolutely. The way their ribosomes translate that little strand of mRNA can be very different. And yes, it certainly can change the viruses that are produced just from individual to individual. But hopefully, it's not a significant enough change that it makes it unrecognizable. I can tell you that flu, for instance, influenza, we get an annual flu shot. Influenza literally can shed its entire cell coat, making itself all but unrecognizable to your immune system every 6 months. It can do it as often as every 6 months. It generally doesn't, but it can happen. But that's why influenza is so, difficult to pin down as a vaccination, against influenza. It is able to change. Certainly, I would never hope that COVID developed that ability. But again, it is something that viruses do. They mutate and change. And as I said, if we can eliminate them by having a large enough number of people vaccinated, by creating a group that is more resistant to the virus, we can hopefully get this kind of the same effect we did with smallpox. You vaccinate enough people, there's not a significant enough population to carry smallpox, and smallpox as a wild strain doesn't even exist.
Thank you very much. Oh, I'm sorry, Dr. Spencer, did you need? Okay. Karen asked, if boosters do get recommended in the following month or so, has there been any plan on how to provide these to OMH employees, and would we be called back in the order that the first doses were received?
So there certainly we are looking at, you know, what that rollout might be. The guidelines currently, again, are kind of the verdict has not come in yet, but the suspicion is that it would be the recommendation that the folks would be vaccinated kind of in the order they were, or folks would receive boosters kind of in the order they were vaccinated. So your older patients would receive it first. The healthcare, you know, folks who are encountering it every day would receive those boosters first. And generally, you know, as it unfolded, you know, the folks that got theirs earliest would get theirs first, and then you would, you know, proceed apace with, you know, with the other groups. We don't quite know what that's going to look like. We don't quite know, you know, how are they going to be provided? If they change the formula, is that potentially going to be something that we can easily get large quantities of? But certainly we are aware that it's a possibility, and we are planning for, you know, that eventuality of booster recommendation. So
Great.
stay tuned.
Yeah, stay tuned. More to come. Thank you, Byron. Thank you, Dr. Spencer. Thank you, Dr. Burlingame Deal. Most importantly, thank you to everyone who attended and our community health partners that joined us today. It was great, unbelievable presentation, and thank you for the participation. For those of you who asked where more information can be found, we only advise not checking TikTok for vaccine information, but we do recommend following Facebook Live tomorrow at 2 o'clock, where Dr. Spencer and Byron are going to be discussing the Delta variant and many topics we discussed today. So there you can find more information on all the socials. Thank you all very much for your time today. We went 30 minutes over, but again, we appreciate you and everything you're doing to keep us safe.
Thank you all.
Thank you, Andrea.
Thank you, everyone.
Thank you.